The quality of patient health records kept by general practices is an important factor in safe and effective healthcare. The primary purpose of a clinical health record is to hold the information about a patient. It should contain accurate data about diagnoses, medicines, and immunisations. Hi everyone, and thank you very much for joining us tonight for part 2 of consistent data quality, ensuring clinical safety standards for your organisation. First, I'd like to acknowledge the traditional custodians of the lands we're meeting on and pay my respects to their elders past, present and emerging, and acknowledge and extend that respect to other Aboriginal and Torres Strait Islander people and elders from other communities who may be joining us tonight. So just some housekeeping. This is a session is going to be recorded, and please, you can also ask a question at any time, and there's a questions tab you can see on your in that pane. Now, to collapse the GoToWebinar interface, just click that orange arrow, and if your screen and sound don't quite match, it's just because you may have some lag in your internet. So the best way is to exit the webinar and then come back, and then hopefully that will restore the connection, or you might have to try a different audio option. So in part 1, we covered the benefits of high quality data records. We discussed some quality improvement and the importance of having an overall and continuous focus on quality improvement. The panel also spoke about how to capitalise on quality improvement measures, and they provided some practical tips to help create a culture of continuous improvement so that data quality could be sustainable. Tonight, we're going to demonstrate for you how to code a diagnosis and correct clinical coding, and how to add past medical history, ceasing out-of-date prescriptions, and including or removing the clinical data from shared health summaries. And of course, then how to record reason for visit or reason for prescription. We'll also cover the importance of allergies and adverse reactions and recording of those, and we will briefly go through active ingredient prescribing. And of course, at the end of the session, we'll have some time for questions from the panel. So my name is Nicola Graham, and joining me is my colleague Brianna Meward. Brianna and I both have extensive experience working in the health system, including practice management and also with the primary healthcare networks. We're also happy to have with us again Dr. Peter Del Fonte to present. Now, Peter is a GP from Adelaide, and he has expertise in digital systems, data governance and change management in general practice. His experience as a leading GP in regional health associations has led to the development of digital tools that support coordinated and integrated care, the quadruple aim, as well as data analytics and mapping tools for population health. And we'd also like to welcome tonight Kathy Drayton. Kathy has a background as a chartered accountant and moved to practice management about 4 years ago. She manages a very busy practice of 20 GPs in southwestern Sydney suburb, and she has found across all industries that she's worked in that quality information is key to running an efficient business. All right, so let's go through now ensuring quality diagnoses and medical history. So clinical information systems provide tremendous opportunities to reduce clinical errors such as medication errors and diagnostic errors, and to support healthcare professionals by offering up-to-date patient information. Having accurate and up-to-date information about your patients helps your practice provide safe, high-quality care and ensures that other healthcare providers to whom you either refer or share clinical documents, such as to the My Health record, provide a suitable standard of care. Now, the main purpose of the patient records is to, as I've just said, to provide the safe, high quality healthcare for the patient and for the practice populations. So using a standard terminology and ensuring that the patient's notes are clinically understood improves health outcomes. It improves quality of your data, which in turn improves relationships with patients and other healthcare professionals. And it can also assist in improving revenue. Now, additionally, your clinical data is a risk management tool, and it assists in the prevention of harm and improves patient safety. Now, we will be going through how to clean up the data in your patient files. However, If you don't constantly enter into the patient's clinical file using the terminology, you'll always have to clean your data, and that is time consuming and it wastes lots of time. So for example, free text terms like high BP isn't really understood by computer systems. So the use of standard terminology allows one system to easily interpret another. So that brings us to the use of standard terminology like SNOMED and AMT. Now, they create a common language which allows one healthcare system to share that information and have the information properly interpreted by that receiving system. And importantly, this information is understood by both computers and also by the human. So these days, all clinical software allows for listed coding. But what about free text? The appropriate use is to elaborate on the condition by entering free text under future detail. Why is it important to use coding? It allows health data to be tracked. For example, you can track all your patients with a certain type of condition. And the main section of EPIP, as you probably are aware, requirement involves data recording and coding. And again, this information transverses healthcare organisations.
So here we can see we'll be using a case study throughout the presentation, and our case study today will be Mr. Frank Harding. Those of you who were with us from session 1 will recall Frank Harding because he was our patient that we used for session 1 as well. Now, please do bear in mind that everything in our screenshots or our walkthrough today may not be 100% clinically accurate or what you would typically see in a patient file because we are just using this test patient data for demonstration purposes today. So as we can see with Mr. Harding, he is 71 years of age. His significant current diagnoses are type 2 diabetes, hyperlipidemia, hypertension, and GORD. And his past medical history is DVT, UTI, inguinal hernia, and childhood asthma. So it is important, as Nikki just mentioned, choosing the most appropriate diagnosis or reason from visit from the drop-down menu that is available in your clinical software rather than free texting. So ensure that you are using a diagnosis or reason for visit when you are entering that clinical diagnosis. So in this software, you can use a reason for visit if the consult is regarding a current medical problem. So if it's regarding a problem that you already have saved in the patient's clinical file, then you can select reason for visit, and that will allow you to pick from the list of existing conditions. So here you can see all the existing conditions listed here. If it is a diagnosis, you can create a new condition where you would click on the diagnosis button, and that gives you the opportunity to type in a few letters, which will then display a list of clinical conditions that you can choose from whichever is the most appropriate diagnosis. And sometimes there are reasons or multiple reasons for visit, and they may not be items that you want to include in a shared health summary or a referral that you're sending off or a care plan. So in this instance, if you are creating a diagnosis that doesn't need to be shared in those summaries, then you can certainly untick the save in past medical history tick box. So here we can see, excuse me, an incorrect diagnosis. So we can see here diabetes has just been free texted and it's not that correct diagnosis. As Nikki mentioned, having that standard terminology and making sure we're coding our diagnosis correctly. So here we've identified an issue with this particular diagnosis that's not coded, so we need to correct it. And this can be done really simply and easily. So we're right-clicking on the condition diabetes and clicking on edit, and then that will take us to the ability to edit that item. And here we can see that, you know, the type 2 diabetes from the list is diabetes mellitus, type 2, and that's the agreed terminology that we'll be using as a practice for this condition. So we've selected it here. And there are a range of other functionalities that you can do in the diagnosis screen. So you can also at the bottom see that there is an option to either send to My Health Record or include in summaries. And that again allows you to choose whether this diagnosis is fit to share in our summaries that we're sending out. So using those free text codes for diagnosis or reason for visit can cause ambiguity, and the correct use of free text information is important for providing a narrative or context. So remember to run audits, and if you do, then free text is often really difficult to retrieve. So we've added some ways that you might see hypertension recorded in a patient's clinical file, and I'm sure there's many more than just what we're seeing here, but this is just to give you an example of how one diagnosis can be recorded a number of different ways. So we're going to do the same thing here, where we're going to edit a previously coded diagnosis, and all you have to do again is right-click and then press edit. And now it is important to have that agreed way that you record clinical information. So that's your standard terminology across the practice. So we're selecting that appropriate code for diagnosis here according to what we've agreed on. And we're recording hypertension using the coded diagnosis from the drop-down list. However, keep in mind that our coded diagnosis needs to be clinically meaningful. So if Frank presented to another GP and that GP saw this diagnosis of hypertension, what does that say about this diagnosis? Is it enough? Is it enough clinical information that would help that other provider that was viewing this information? So do you need to put more information? And that's where the free text can be really well utilized to enter that further information using that free text box. So it'd be a really great opportunity to hear from Dr. Del Fonte on the line now. So Peter, now that we've had a look at the examples of how to code correctly in a GP software, would you be able to speak to the importance of the correctly coded diagnosis and what considerations should we keep when coding from a GP perspective?
Sure, thanks, Nikki. Look, I think, first of all, the last three slides, I think, covered very clearly the way that we can correct a diagnosis and enter a diagnosis and not use free text. I think the key thing is understanding that the diagnoses that we have in our clinical information systems are there to assist us, obviously, as our aid memoir, but importantly, when we're coming to sharing information, it's very important that not only does the care continue with allied health or specialists, but there's also information continuity and being clear, such as the diabetes, a good example, is it type 1, is it type 2? And if it's a type 2, are they taking insulin or not as well? So the clearer that information is, and the more and the better structured it is, the better understood when it's received by another clinician when you do a referral letter or a summary or an upload to the My Health record. I think the second point I'd like to make is understanding what is active current diagnoses and what is a past history. So someone might have depression when they're at university 20, 30 years ago. You may want to record it there as a past history. You may not even want to show that on a health summary because it's something for you to use. You may want to keep that, or the patient may want to keep that bit of information confidential. So you would have seen the opportunity there to also tick confidential. And if you do this right and keep that health summary as up to date and accurate as you can, I try to do that certainly at every consultation when I review the patient and realise they've changed their medications or they've had another allergy reported in the hospital or changed a new diagnosis. I will enter that information there and then. If you start that process from the very start of the patient's journey, then updating that information is going to be just whenever you need to, and it's just going to be a small amount of work to keep that information up to date. And keeping that information up to date, as I said, will also help you from using some of the clinical information decision tools that are in the CIS in assisting whether this drug is compatible with that particular diagnosis or drug-drug interactions. So keeping that information as up to date as you can at the point of care certainly ensures that there are no near misses or mishaps that can occur purely because there was a lack of data there or the quality of the data wasn't particularly presented in a way that other systems in your CIS can utilise and provide you a warning or indication that just take a second look at this before you prescribe this drug. So look, there are a few other things as well. Just when you're uploading to the shared health summary, uploading a shared health summary to the My Health record, you shouldn't have to tinker with that shared health summary. You already know what is confidential. You already know what are the current, what are the up-to-date list of diagnoses and past history and medications. So that it's a matter of just one click and it's uploaded. Look, I'll stop there, and certainly I'm sure there'll be a lot of questions as we go along, and certainly at the end. But I think the key point here is that keeping data up to date just makes that journey of the consultation a lot safer and higher quality, and also helps you with monitoring progress with the patient.
Thanks so much, Peter. That's really valuable. And one of the things that you mentioned was in regards to ensuring that we can add in those past medical histories, which Nikki's about to talk about in a moment. But just to finish off the topic around correction of uncoded diagnoses, most clinical information systems will allow you to complete a bulk cleaning of the free text diagnosis or incorrectly coded diagnoses. So here you can see that the free text or uncoded diagnosis was identified, and then you can choose how to relevantly correct that commonly poorly coded diagnosis. So again, it is really important that you have agreed terminology that is used when coding the diagnosis. So for example, how each clinician agrees to record a coded diagnosis of diabetes. You might be doing things differently, so having that agreed across the practice. And it is important to mention as well when looking at this bulk correction option for those commonly or those common mistakes with diagnosis is that the bulk coding needs to only be used where appropriate. And of course, goes without saying, but not all instances will apply to the suggested correction that comes up. So it is a great option though, and it is there and available to save time with those, common coding errors that we see. And so it'd be really great now to hear from Kathy, our practice manager on the line, about your experience with managing that poorly coded data. And with so many GPs in your practice and other health professionals as well, could you share some of your strategies around how you've implemented the correction of poorly coded data?
Sure. So I think the most important thing as a practice manager is to make it not overwhelming for GPs, nurses, whoever is helping out with the process. So it's about taking bite-sized chunks that is manageable in your practice. Often we've inherited bad data because of something that's happened in the past. It might be a data migration from an old computer system where it wasn't coded. So it's about taking small bites, this bulk correction of uncoded diagnoses. Sometimes it's something that I do while I'm listening to a webinar that doesn't need my full attention, and I can have a look at this sort of data. Using tools, so a lot of PHNs provide either Polar or PenCat, and looking at recipes. So for example, you might be looking at coding your diabetes in my practice, that wasn't such a big issue, but then we were looking at CKD, and that was overwhelming, trying to get that coded correctly. So by looking at the patients that were most at risk and giving each doctor a bite-sized chunk made that a much more manageable process. And once they were coded, then we could look at the next lot of risk in that area. Managing your staff in this relation is also really helpful because in some practices, and it'll depend on your practice, this might be something that you can assign to your nursing team, for example. You might be able to run a recipe from Pencat or run a polar report and then hand it off to your nursing team to do the proper coding. So knowing what staff you've got and who's got the most capacity for it is also a very important part of that.
That's great. Thank you so much, Kathy. There's some fantastic tips, and I think we were going into a few more tips at the end of the webinar, but they're really good to think about assigning it to someone to help you with that coding and correcting that data. All right, so let's now talk about past medical history, and Peter did allude to this a little bit before. Past medical history can also be called a problem list in some clinical information systems, and we know it can be full of redundant data. So when past medical history is not used correctly, it can result in, and Peter did mention this before, like failure to treat or to follow best practice guidelines, or failure to even consider relevant surgical history or comorbidities. So to avoid these issues, it's important to only enter chronic conditions and significant events in past medical history. Now, this is something that a practice manager or a systems admin could set up through the clinical information systems settings or preferences. So consider when entering the history to select either active or inactive, and also you can use free text to help. So obviously you could enter the specialist looking after this condition, the type of surgery, etc., and the date of diagnosis. So you can enter a fair bit of detail in that data there. Now, you may also enter a past medical history that you don't know much about. So, for example, here you can see we're entering the condition GORD, but if you don't know the actual date of diagnosis, then under the further detail, you could make the note diagnosis made at a previous GP clinic, unknown date, and that really just gives some context around why you haven't added that date. So removing resolved clinical conditions from active to inactive is simple, and it's really important, and it can be done when the patient's with you. Now, Peter said before that he does a lot of this information and checking when he has the patient with him, and here you can also remove duplicated or insignificant reasons for contact. So sometimes you might have a script visit or something like that. So again, to make this inactive, you just simply right click, select Make Inactive, and then it will appear in your inactive problems. So you don't lose the data, it basically sits in inactive, so it will then be there available for you. So once we've made that problem inactive, we need to also then consider the relevance to share in summaries. So what's the clinical relevance of sharing the medical history with other healthcare organisations via the referral, the shared health summary, or even transfer of patient files? So we need to ensure that you edit and untick to include My Health Record in summary. So is the fingernail removal clinically relevant to share to the My Health Record, or include in any summaries or clinical information that you share about that patient? Now, importantly, like I said before, when you remove the information, it's still recorded in your CIS or your clinical information system. However, it just won't be included in the referral. So you can see here, the asthma childhood will be included. It's significantly relevant, but the fingernail removal isn't as relevant. So you can see it's highlighted that no, it will not be shared. So you're aware of what's actually happening. So Peter, we've gone through now how easy it is to add past medical history to make it out-of-date data inactive, and also to consider including and excluding this history. Could you talk about the clinical relevance and the importance from a GP perspective to add or correct this information?
Yeah, sure, Nikki. Look, I think you've covered certainly the key points and the process of doing that. The important thing is talking to your patient. Sometimes something you might think is not that clinically relevant to share, they may think it is. Having a fingernail removed, and it's growing back to normal. From a clinical point of view, it's probably a bit of history there, but it's not going to make any difference from their chronic disease management or whatever. If it hasn't grown back, or there's been something complication from that, then I would probably keep that in and maybe put some notes from what happened to that as part of that surgery. Especially if they've got diabetes and that sort of thing, and they're going to see a podiatrist, it's probably good for the podiatrist to have a bit of background history of what happened there. It might have been a traumatic thing, but it could have been some other reason. So what's important also is, and it comes back to that few slides back around reason for visit. If the reason for the visit is to do with the hypertension, that it's just, you've got the one diagnosis, hypertension, 5 years ago, you've got it there, that's the current diagnosis. The reason for visit, you don't want to make a new diagnosis on that day, which is what the fault of many of the systems have been in the past. And that's created these repetitive hypertension in your diagnosis list. If your system still does that, then don't make that the default option. You want to only enter a new diagnosis at a consultation. It probably could be the reason for the consult, but also it's the fact that you was diagnosed at that particular consult, and that's a new diagnosis, and it's a one-off entry into the diagnosis list. Making things inactive and active really, again, that's your clinical judgment and to whether something's resolved and now it's put in the past history, and whether something is confidential as well. You can tick all these things as you've been shown in the last slide. Very important, again, that it sounds or looks onerous, but if you start the process like this, then each time you're seeing a patient, you probably won't be doing too many of these clicking and unclicking and making inactive and active. But it's a good practice to do it, and then at any one point in time, you will have an up-to-date health summary with the latest current diagnoses and medications and allergies and whatever else you want to put into that referral letter or upload to a shared health summary. So look, again, there's probably nothing more to add. The important thing is use your clinical judgment as what you want to include in the summary at all. So you may not want to include anything in there. You may want to delete some things if they're clogging up your list of diagnoses or your referrals, and you think, it's probably an irrelevant bit of information. You can just delete that completely. It's probably unlikely to happen. Certainly, if it's a lot of reasons for visits, I found where I had something like 40 entries for things like phone call, referral letter sent, immunisation given. I just delete all that and clean that up and make it as good as you can at that particular point in time. And hopefully, once you've got it set correctly, it's not that onerous to keep that up to date as you see the patients over time.
Thanks so much, Peter. There's some really brilliant observations and comments there. And one of the main ones that you said was in regards to reason for visit and how it can really skew or clog up our data. So what you can see here on the screen is a snapshot of the user preferences, where we can start to create some default settings or allow or save our default settings to contribute to a better data quality. So we know that reason for visit is not often recorded properly in systems, and it can often be left blank in the patient health record, which will mean that there's sort of insufficient information for that clinical handover, and clinicians may also miss important information, resulting in poor continuity of care. So that's really important to include that. And the setting for the clinical information system can be changed to make sure that the user receives a prompt to enter reason for visit when closing that patient record. And this is also something that a practice manager or a systems administrator can manage. And so it's really important to also consider, as Peter mentioned, changing that default setting so that the reason for visit or reason for medication doesn't also auto add to the past medical history list. So we don't want to see all of those reason for visits continuously adding to past medical history. We can untick that from our user preferences, so that's not a default setting, as Peter just mentioned. So this is a visual look at what that is in one of the clinical information softwares and how that can be changed to help your data quality. But it'd be great to hear from you, Kathy, around these defaults and have you utilized them, and how do you manage such a large practice with these default settings for maybe some of us who aren't as familiar with these?
I think the most important thing is to know what your ideal settings are in your practice, and certainly we've got some examples there. Once you have a user that you've set up using those ideal settings, anytime you onboard a new doctor or a new registrar, you can clone those settings. So up that top right-hand corner is the cloning button, and that automatically copies it across, because if a new doctor's starting, they don't know what your system is doing, so you can't expect them to know to change their own preferences. You may have super users or doctors already in your practice who do know what they're doing and are doing this consistently, and may have ticked on or off some of their settings. But you'll probably have other users who just have always done things always the way that it is. And so it may actually be worth going back through your existing staff or existing doctors and just looking to see if any of those need to be cloned as well, so that you end up with this optimal space where everyone is doing the same things the same way.
That's awesome. Thanks so much, Kathy. That is certainly a really handy function to be able to clone those.
Thanks, Kathy. All right, so entering a reason for prescription as structured data where clinically relevant can improve the quality of our patient's health record. So we've been talking about reasons for visit, and like reason for visit, reason for prescription is not always used. So when you prescribe a medication, you may be prompted to add this reason for prescription, and you would just simply select from the existing coded list. So here you can see the list here. So you could simply select from one of those lists. Now, if the reason for visit is already recorded in the clinical information system, like in this example, so you can see that we've got reason for visit is GORD, then you'd make sure that you do not tick over here, save as reason for visit, or to add as diagnoses. And if they are already ticked, then consider deselecting them so they don't, as we were talking about before, clog up the system with a lot of extra information. So thinking about the shared health summary or a referral, what are the clinical implications of including ceased medication in shared information? Now again, this can be easily corrected to ensure that only current medications are recorded by ceasing prescriptions that are either ineffective, they've got allergy or an adverse reaction or a drug interaction, or even that they're no longer required. So these prescriptions should be removed from the current medication list and ceased. Now, to do this, again, it's very simple, and as Peter said before, you can do this while you've got the patient with you. Right-click to choose cease medication, as you can see on your screen, and then you'll be prompted to enter a reason. And I said these are some of the reasons: the ineffective, allergy, or adverse drug reaction, or no longer required. You will be prompted to do that. So you'll have to choose one of those and then select delete. Now, the reason for prescription, as I said before, is not often recorded in the clinical information system, and not having that recorded can lead to over or under prescribing, unnecessary hospitalisation, and that's due to lack of patient understanding. So you can edit the reason for prescription from the patient's current medication. So you can just go in and do this, all of them while the patient's with you. And then select from either existing clinical conditions, or you can add a new condition. So that's really important. So if it's a new diagnosis, you can type in a new condition, and as Brianna had before, add a few letters and then search for a condition. Now, once you've done that, enter the reason for the medication by selecting the coded list. And now we do know that if the clinical diagnosis has already been made, you won't need to select add to diagnosis or add to past medical history or reason for visit. Now here you can see not only will the clinical file have updated information, it also includes the clinical conditions in any shared house summaries or even information that you share with other healthcare providers for patient transfer with the reason for this prescription. Now this is very important, and I guess Peter, if you could talk a little bit about why is it so important to have that reason for prescription, and how important is it for the patient and other healthcare providers to have the reason for prescription detail in there?
Yeah, thanks, Nikki. Look, I think certainly people might have seen patients come out of hospitals with the discharge hospital pharmacy list of medications and reasons and that sort of thing. And patients absolutely like that, because they, for the first time, have understood why they're taking a particular medication for a particular condition. So first of all, from a patient education point of view, it makes sense. When you're communicating to your clinicians, now you could argue, well, I'm on, cholesterol medication, so you kind of think, well, you must have high cholesterol. Some is obvious. You may be taking an ACE inhibitor because of heart failure, a very low dose ACE inhibitor for heart failure, but not because you had hypertension. So explaining the clarity around the reasons for prescribing, I think are, if you like, are pretty useful in terms of both the patient and the people you're communicating with. But also remind yourself as well that the main reasons you're prescribing some of these things. As I said, some of it, invariably most of it, is intuitive. The medication is for that condition, but some medications have multiple conditions that you can use them for, and makes it clear to the others that you're referring patients on as to what that particular medication is being taken for. So, and the other thing there is the importance of cleaning up medications. Again, do that at every consult. Check patients. It's a good way to check compliance as well at the same time. But also when you're coming to use your drug-drug interaction decision support systems, if you've got drugs that they're not on, you're going to get a bit more of those dialogue boxes saying this drug will interact with that drug when they're not on that medication at all. So it also speeds up a little bit in that process of selecting a new medication, not having to go through too many of those dialogue boxes. Lastly, I think the important thing is deprescribing is very important because if scripts are left on there and some other doctor might not be aware that that's actually been deprescribed and it's just persistently on the list, they may want to just say, well, they're on that, let's just prescribe all that and then go from there. When in actual fact, because the patients sometimes are just unable to articulate the fact that they've stopped that medication or no longer taking it. So lots of reasons to keep that as up to date as possible. And the last one is when you're uploading a shared health summary, then this is the current list at that point in time. And again, that information is shared across a whole host of other potential providers in the future that may see that patient, particularly if they're going interstate or travelling away from where they normally live. So all good reasons to keep that information up to date.
Yeah, thanks, Peter. That's actually fantastic. And I guess one of the key points from that is it's really great for a patient to understand why they're taking that medication, and maybe they can help their own. But I guess that's a great segue into the allergies and adverse reactions. And obviously, this is you mentioned about health summaries. So this the health summary is actually meant to reduce the risk of inappropriate management, and that includes medication interactions, as you just mentioned, and adverse side effects. Now, that's particularly when allergies are recorded only. So having accurate and up-to-date information on medicines means that you can achieve best practice prescribing. And Peter, you just exactly said that. So if allergies and adverse reactions are not captured as structured data within your clinical information system, again, Peter also mentioned this, that you can miss contraindications when prescribing and important information about the severity of a reaction. It's also important to upload allergy detail and update whenever you receive a known allergy from other healthcare providers. So it's important to ensure to record details relating to the allergy and adverse reaction severity, including as much information as possible. Now, I'll just go to the next one. So, Peter, could you just quickly tell us, just clarify for us, there's so much confusion. What is an allergy and an adverse reaction, and what's the difference, and how do we record that differently? Just give us an idea about that.
Sure. Well, allergies are obviously to do with the immune system response, creating either a local reaction or a systemic reaction, anaphylactic type reaction. It doesn't have to be just to drugs. It can be to a whole host of things, from fruits, dust mites, a lot of things that can cause allergy. So, but it's the mechanism of which it generates that response that's important. And that's distinctly different to, and the issue there around the allergy is obviously whether it's a local or systemic or severe, moderate, whatever. And obviously, the better documented that event is, the better is for future clinicians that say, well, yeah, you definitely had a penicillin reaction, you went to hospital, had anaphylaxis, etc. Versus an allergy sometimes that is presented to you by the patient as an adult who said, my mum said I had an allergy when I was a kid at 2 years of age to penicillin, and it might be. And as we know, often it's not the case, and it might have been coincidental viral rash at the time that penicillin was given inappropriately for a viral illness. So sorting that out can be a little bit more tricky, but it's important to know that. An adverse reaction, and in this case, is really more an adverse reaction that is kind of expected or even unexpected to the medication itself. So it might be causing nausea, vomiting, might be causing person to feel unwell. That's a different sort of mechanism, and sometimes, as I said, more often than not, it's kind of well documented, those adverse reactions in relation to that particular medication.
Yes, so that shows on this slide that we're looking at now with, and you're mentioning the penicillin allergy. So here, to make sure that obviously the reaction and to make sure the nature of the reaction and the severity, and making sure that that information's up to date to clarify. And would you recommend putting a comment in there as well?
Ideally, yeah, and it might be such as I've just said. It might be that they've had a maybe not a severe reaction, but they had they've reported an allergy reaction, and comment would be in childhood when 2 years of age and nil issues since. Whatever you like to write, but the important thing is understanding that how well the better documented and witnessed, if you like, and by in a health setting, this allergy, the more weight it has in terms of understanding that. However, you go obviously on the caution, because you don't. If someone says they had an allergy to penicillin as a childhood, unless you can prove otherwise, there's ways you can do that, but you probably have to take that at face value and use some alternative antibiotics.
Yeah. All right. Well, that's fantastic. Thank you so much, Peter. And I guess this slide really shows you, highlighting the importance of adding that information in. And again, you can just simply edit and add the reaction into the clinical information system. So here we have now alerts when prescribing, and again, Peter mentioned about this. So if allergies and adverse reactions are not captured as structured data within the clinical information system, you are going to miss out on the contraindications when you're prescribing, and also important information about a severity of a reaction, and Peter's certainly spoken about that. So documenting the patient's clinical note and in the allergies and adverse reactions, it will allow to trigger those alerts, and it'll happen for the clinician and any other providers. So Brie, I'll let you talk about active ingredient prescribing.
Thanks so much, Nikki. So just moving on now, while we're talking about the topic of medications, we thought it was important to talk about active ingredient prescribing, which became mandatory from earlier this month, so February 2021. So active ingredient prescribing will ensure that patients receive consistent and standardized medicines information, and prescriptions will list active ingredients by default rather than the brand name now. So when prescribing a new medication, you can still search by the brand name or active ingredient. So in most cases, your workflow won't change. And you can prescribe a specific brand of medication if you believe it's clinically necessary, and can just choose to include that brand name on the prescription along with that active ingredient. So the active ingredient will appear first before the brand name on all prescriptions, medicines packaging, pharmacy dispensing labels, and in the My Health Records shared health summaries as well. And consumers will still be able to have the choice about which brand that they want to get their medicines from their pharmacy as well. So it is important to note that you can search and select your medicine according to the active ingredient or the brand, depending on which software you're using. But in most cases, like we said, your workflow won't change. So for example, with our test patient Frank, if we want to prescribe Mycardis, we can search Mycardis, which of course is the brand, not the active ingredient, and still select it from the list of medications. But what we'll see when we progress through this prescription is now a tick box that allows us to select whether we want to print the name on the script and whether or not we want to allow brand substitution. So it's important as a prescriber to consider if it's clinically necessary to specify the brand or not. And then do that using the tick boxes. So the prescription will then be generated to state the active ingredient followed by the brand if it was indicated by you when prescribing. And then again, it will also tell the pharmacist whether or not a brand substitution is permitted, depending again whether or not you've use that tick box functionality. So in some circumstances, it is preferable to prescribe a medication using the brand name in addition to the active ingredient for whatever clinical reason you determine or patient safety. And in those cases, it is important to make sure that you do tick the include brand name so that it is allowing us to prevent any risk of medication related harm, especially for our high risk medications, high risk consumers, and or high risk situations where formulations may not be interchangeable due to things such as variations in delivery of the active ingredient and so on. So making sure that you know that that box will be unticked by default and you will need to tick it to include the brand name. And if we look at the two types of scripts now, we can see on the left-hand side, if we prescribed Mycardis and we didn't tick brand name, we can only see the active ingredient there. So we're seeing Telmastan, if I'm saying that right. I won't attempt that again. So I'm clearly not a pharmacist. Peter, you can probably say that correctly, but we can see the active ingredient there and all the information that we would usually see on a prescription. However, our brand is not included, and that's because we didn't tick the box. Whereas on the right-hand side, if we've determined that we do want to include the brand name, we've ticked the box, and we can see here now our active ingredient followed by the brand is included.
Thanks, Bree. So now with over 90% of Australians with a My Health record, it means that GPs are no longer producing health records only for the benefit of themselves or their immediate colleagues. So GPs in practice will at some point have to share the information they enter into a patient's health record, and it might be used by a range of health professionals and services to provide health care. And it might be accessed by the patient themselves, and that's important to consider. Or it may even be required by third parties, for example, medico-legal purposes. So maintaining high quality health records is integral to good patient care, and of course it has a range of other benefits. So the quality of data that goes into your medical software equals the quality of data that you extract. So by having good quality data, you can use to analyse the data to assess patients with particular medical conditions. You can find gaps in care and assist in improving practice processes. Data analysis can also assist with meeting accreditation requirements, and that's by finding gaps in the practice data. And so, for example, no recorded allergies. So here you can see the first step in creating the shared health summary. Now, when the clinical file is kept up to date, as Peter said, uploading the shared health summary is very efficient and it doesn't take any time at all. Now, medication errors have a significant implication on patient safety, and these errors occur at all stages of medication use: ordering, prescribing, dispensing, and administration. So here you can see a fully completed reason for prescription list. Now, this helps to improve accuracy and visibility of medical information. It also helps reduce errors that will significantly improve patient safety and the quality use of medicines. So here you can see the referral letter. Now it is sent to primary, to secondary, or to tertiary care, and it's an important document that really facilitates that transfer of care from the general practice. So the quality of the clinical information in referrals must be fit for sharing and must be of the highest possible quality and contain all the correct information. So here you can see the referral letter, and obviously there's going to be a lot more detail in the introduction of the letter. As Bree said, this is only dummy data, if you will, and so we haven't actually added more detail, but you would normally have a lot more detail in your introduction. However, the clinical data contained in the letter now is accurate and up to date. So spending time updating your patient's file ensures the clinical information that is shared with other healthcare professionals will be able to facilitate safe and effective care.
Thanks, Nikki. So to summarise, before we get on to our panel discussion portion of the webinar, we can see here some really great tips for maintaining quality health records at your practice. And we know that improving our data quality can often be a journey, and it's a great idea to have a think about your practice and what some strengths are that you have and where we might be able to focus our energy when looking at improving our data quality. And we can see some examples here where we might want to do that, including making sure we allocate some protected time for data quality activities, making sure that we do a bit of a scope of a patient file before and during a consultation, as well as thinking about things such as our standardized terminology that we're using and communicate that throughout the practice, and looking at making sure that we're recording results and assessments in the right places in our software, so getting to know our software and communicating that again amongst the staff, and also having scheduled audits. So as Kathy mentioned, she does that on some quieter periods in the practice. And finally, making sure that we utilize all of the tools available to us, and your local PHN is a really great place to get some support around data quality, because they'll be able to provide you with some of those middleware softwares. And Kathy mentioned that she uses PenCS or PenCat that was provided by the PHN, and they can go through some PDSAs or some Plan, Do, Study, Acts where they can support you with your data quality in the practice. So Kathy, while we've got you on the line, can you share your top tips for working on data quality in your practice that you found over the years?
So the first thing is to respect the fact that all clinicians will have a slightly different style of working. So if you make it too prescriptive, you're going to have pushback straight away. But most of the software that we use is sophisticated enough to enable people to work the way that they like to work. The second thing is to look at your staffing and see where you can fit this in. So for example, a lot of us will get registrars every 6 months, and registrars often are the least utilised GPs in the practice. So they've got a little bit more time up their sleeve, but they're also the people who are going to be seeing our acute patients because they do have the greater availability. So it's in their best interests, if you mention to them that that's a role that you'd like them to take on, is that when they do have that extra time, that they use the time to actually actively review the clinical information and the quality of the information, so that if another registrar has to pick up the patient in the future, that the coding is much better for them and they're able to more easily pick up that patient and treat them in an appropriate manner. But I think the biggest thing in our practice is, because it is so busy and most of my GPs struggle for time, is by doing small elements lots of the time. So for example, we make it every time we have a doctor's meeting, I'll make sure that I bring in one very small process improvement that they may not know about, and then I'll provide them with the best practice guide that goes with it, so that in their own time they can review and work out how to do it if they're not don't know already. But it could be something as simple as reminding them the age of smoking status is the age of 10. And so they can start sort of working on those things. So it doesn't need to be big items, just small items, but more regularly, so that it's part of the process.
Yeah, that's awesome. And I think that's a really great practical tip that you're sharing with us from your experience with so many providers in one practice. I'm sure it's been a challenge, but it's good to hear that it is achievable with those small bite-sized pieces of work. So just moving on to the final summary slide before we hopefully we'll have a couple minutes to answer a question or two. This is just, again, a final summary of the examples we've shown you through the clinical information system today. And regardless which clinical software you use, these same strategies should be available to you. So again, get to know your software and work out how this looks in your system. And what we're actually doing as well is planning some on-demand training sessions where we'll actually use the clinical software test environment to further demonstrate how you can implement these strategies within your particular clinical software. So keep an eye out for those as well. Now on to a couple of questions that have come through. The first question that we've got is, I'd like to know more about the type of medical terminology that is used, and is there a link? Nikki, this might be a good one for you.
Yeah, thanks, Bree. So most certainly there is some information, and on one of our slides at the very end, we've got a link to SNOMED and AMT that the agency have, and you're able to interact with it. You get lots of key tips. So it's like a real little community. So I recommend going on to that. And we do have that as part of the slide deck. So at the resources slide, Bree will highlight that for you.
Thanks, Nikki. And I think we've got one more here in regards to just a final kind of message from our two panel members. Someone said, we're getting ready for accreditation, and when I look at the quality of our data, I feel overwhelmed. What are your tips for improving this, and how do we keep the momentum of quality improvement? I think that's an excellent question. Maybe we'll start with you, Peter.
Yeah, Nikki, a very important one, accreditation, and obviously people are aware that 90% of your allergy coding and smoking coding need to be something coded in there, and that means if you don't know that if the patient doesn't have an allergy, you click unknown. You don't leave the question mark there. And smoking status is very important. If they don't smoke, just put never smoked, ex-smoker, or current smoker. Just that alone will get you 90, and you want to do that for 90% of your patients. And again, every time a new patient comes in, I ask them as the first two questions before we even talk about anything else, because that's important for accreditation and getting that right. The other thing is just the health summary. Keeping as much as you can a health summary up to date. Obviously, from an accreditation point of view, I'm not going to know whether that is up to date. But if I see a lot of old medications that are 3-5 years old, now it could be that they're taking, but the specialist is prescribing them. So just again, I would focus on medicines, keeping your medication list up to date. If you keep your medicines and allergies up to date, I think you could be forgiven for having free text type 2 diabetes, because everyone can at least understand what you meant by the free text diabetes. But medications, as we said earlier, will lead to a significant number of medication errors and adverse outcomes for patients, and a significant number that go to hospital as well, all avoidable from a safety point of view.
Excellent. Thanks so much, Peter. And we have come to the end of the webinar now, so we'll just quickly display some useful resources. As Nikki mentioned, we do have some data quality resources, one of which is the data quality checklist. So this is available to you to share around your practice. It is on our website. And then also we have the links to some really great resources from a range of other organisations, including RACGP, AAPM, and then also there's that link to the SNOMED and AMT terminology that Nikki was referring to, where there's a lot of really great resources and that sort of community feel when it comes to that topic and sharing information there. So do jump on if you do have any questions. And finally, there is also the Primary Health Network locator if you'd like to contact your PHN if you haven't already about getting that support. And if you would like to contact the agency for anything around data quality or My Health Record or any of the agency projects, please feel free to contact us on the 1-800 line that you can see there. Number 2 for providers will get you through to our provider line, and follow us on LinkedIn, Facebook, and Twitter for regular updates as we move forward. Thank you again, everybody, for joining us. As Nikki mentioned earlier, everyone will be sent these slides following the session today. And please remember to fill out your evaluation that will pop up once we end the webinar. And we would love to get your feedback on tonight. Thank you again to our panel members, Dr. Peter Del Fonte and Kathy Drayton, for joining us. It's been a pleasure. Have a good afternoon.
Thank you very much, Dr. Peter Del Fonte and Kathy. Thank you so much for your contributions tonight. And good night, everyone.
Good night.